भूख लग गई
कि
रितु
ये से स्टार्ट कीजिए।
I can start. Hello, colleagues and friends across the globe who are watching us. I'm Dr. Rajiv Kovil. I'm a diabetologist with centers in the western suburbs of Mumbai. I'm here getting you Diabetes News Nucleus, which is an effort and an initiative by MedTalks, and it is supported by Mankind Pharma. So we are going to give you the top five or four or five headlines this particular month. And then we are going to introduce the guest of this month, which is Dr. Sunil Jain. We have always wondered that there have been no proper gender representation of male and female in many randomized controlled trials. And many a time, studies which are done in men are extrapolated to women. Now, here we come across one interesting study which got published in the JAMA, and it says that women between the age groups of 45 to 65 with diabetes have a tenfold higher risk of coronary artery disease as compared to women in the same age groups without diabetes. So, diabetes exponentially increases the chance of CHD in women with diabetes versus women without diabetes. Another very interesting finding from this looked at, they followed up women for almost 2 decades, and 28,000 women in the Women's Hospital in Boston, Massachusetts, were followed up for 2 decades to come up with this kind of fantastic longitudinal epidemiological data. And again, we are looking at many biomarkers of which can predict coronary artery disease in men and women. And this particular study looked at 50 different biomarkers. One specific biomarker which actually had a 600% prediction of coronary artery disease, especially in women, was something called as lipoprotein insulin resistance score. And this lipoprotein insulin resistance score is a combination weighted of multiple of the sizes and the concentration of the lipoproteins. So the size of HDL and LDL and triglycerides and the concentration of HDL, LDL and triglyceride is put into a weighted average, and you get a score. And that score seems to have a 600% prediction of coronary artery disease in this particular longitudinal epidemiological study, in which LDL cholesterol had only a 40% predictive value. So in future, we would have much better biomarkers, and this emerged as a wonderful biomarker among 50 other biomarkers. So in future, we will have a lot of biomarkers which can help us predict coronary artery disease in patients with both diabetes and without diabetes, and also in men and women in the same way. Second thing about another very interesting article which appeared this month was a study called as Cardia, and it looked at gestational diabetes, patients with gestational diabetes, and what was their risk in terms of cardiovascular disease. We all know that patients who get gestational diabetes, or people who get gestational diabetes, I should not be calling them patients, uh, people with gestational diabetes are very high risk of developing diabetes in future. And this gestational diabetes help us in picking up those individuals who are at very high risk for developing diabetes in future, and it gives us a window of opportunity to actually intervene and make sure we can put preventive measures to make sure they do not progress towards pre-diabetes and diabetes. This Cardia study actually looked at women between 18 to 30 years of age, and again from 1985 to 1980, from 1985, and then again followed them up for almost 2 decades. And all of them, out of which almost 12% developed gestational diabetes. And if you look, and they underwent OGTT and HbA1c almost 5 times all throughout this longitudinal study. And what was seen is that people who developed gestational diabetes and later on became normoglycemic had a coronary artery calcium score which is equivalent to patients with incident diabetes, which again tells us that gestational diabetes seems to have ramifications in future. So not only prevention of diabetes, but people who become gestational diabetes and get into normoglycemia are also at very high risk for cardiovascular disease. So these patients, we need to put a lot of preventive measures, whether it's control of lipids, control of blood pressure, and all the other metabolic features which drives the cardiovascular epidemic globally. So this was a very interesting study from cardiovascular standpoint. Another very interesting study, which again came in the Lancet this particular month itself, looks as that cancer seems to be replacing vascular deaths in excessive deaths in patients with diabetes. What is predicted is that by 2030, cancer would have replaced vascular deaths in as the highest cause of mortality globally, and that's a huge worry. 27% of patients with type 2 diabetes have some form of cardiovascular disease. The chances of getting liver as well as pancreatic cancer in patients with diabetes are almost two times as compared to the general population. Very similar to the risk of cardiovascular disease in patients with diabetes as compared to the general population. So in future, we may actually end up screening people with diabetes for not only cardiovascular disease but also lot of types of cancer, out of which liver and pancreatic cancer seems to be much higher. And it's very interesting to note that among the NCDs, cancer is going to replace cardiovascular disease as the leading cause of death by 2030. Another very interesting article which actually appeared just last week looks at injectable semaglutide at a higher dose. Now we all know that obesity and the metabolic features in obesity drives a lot of metabolic complications, whether it's obstructive sleep apnea, knee, osteoarthritis of the knee, diabetes, dyslipidemia, cardiovascular disease, chronic hypoventilation syndrome, and all these things. So obesity is one of the highest medical disorders, but unfortunately in India, obesity has not been treated as a medical disorder. Injectable semaglutide, which is a once a week GLP-1, had a fantastic study, which is a randomized controlled study of 60 weeks, which looked at patients who are above a BMI of 30. And what they showed is that there was almost 67 to 70% of patients followed up over 60 weeks had a 10 to 15% drop in their body weight, and almost 32% had a more than 20% drop in their body weight. So the next biggest thing after diabetes, and we all know obesity has been driving diabetes, and that is why we call them as two sides of the same coin and diabesity. So in a short period of time, all of us would like to go down to the root of the problem, which is the metabolic syndrome or metabolic features in obesity, because the excess deposition of fat in the organs and ectopic fat in the organs seems to be the harbinger or the hallmark of metabolic syndrome in people. And once we start treating this earlier, we can have a lot of emergent risk reductions in obesity and obesity related complications. Now let's come to the topic of the month, which is time in range, and is it a good metric, and is it going to change the surrogate markers of glycemic control that we have today, which is HbA1c. And to discuss this in detail, I have none other than Dr. Sunil N. Jain, who is one of the topmost endocrinologists in the country. He's the director of the Total Diabetes and Hormone Clinic and Hospital in Indore, and he's a very good and close friend. I'm in awe of him because he is one of the front runners of technology in diabetes across the globe. And the amount of people who go to him, doctors who go to him for training in technology and training in the way he has set up his institute, we all are followers of him. So it's a proud privilege to have him here. And we go to have a discussion with the technology man in India on something which is called as time in range. So Dr. Sunil Jain, welcome to our show. Thank you so much for being here. Thank you so much.
Thank you.
So my first question to you, Dr. Jain, is that blood glucose has always been one of the markers for glycemic control and also for complications as such. Now we are looking at interstitial fluid glucose, and it is emerging because a lot of our organs are also in the interstitial. So what is your comparison between interstitial fluid glucose and blood glucose?
So one is a interstitial fluid glucose, which is bathing our cells, which we are measuring through the technologies which we call continuous glucose monitoring. and we are going to discuss it further. And another area is the blood glucose, which is flowing in our arteries, veins, and capillaries. Now, the blood which is flowing in the capillaries, veins, and arteries versus interstitial fluid glucose. So ultimately, both these compartments have their own value. For example, when we use the word hypoglycemia, currently our definitions are based on the measurement coming from the blood. While in an interstitial fluid glucose, it may dip little lower in physiology also. And in addition, the changes which are happening in the blood are instant when the glucose is changing. While the same thing will get reflected in the interstitial fluid glucose after few minutes on an average around 8 to 10 minutes. That's what we call it as a lag time. So, in a steady state, the blood glucose and interstitial fluid glucose will be more or less same. But when the glucose level are changing fast in the blood, we will see the same reflection in the interstitial fluid around 8 to 10 minutes later.
Thank you so much, Dr. Sheikh. So, how do we measure interstitial glucose? Tell us something about the available CGMs globally and what is available in India as well.
So to measure glucose, whether it is in the blood or it is in the interstitial fluid, we know that there are enzymes which will work on the glucose, will create some electrons, and that's how we read the glucose, and that is what is the various technologies which you are using in the laboratory. More or less same technology, but with a very stable enzyme preparations have been coated around a platinum electrode, and this electrode, when it is placed in a subcutaneous tissue, can measure the glucose more frequently, very frequently. Like when we do a test on a glucometer, we put a strip, we put a drop of blood. Again, this strip is having a reagent which is acting with the glucose and creating a small current which is measured by the device. But that can happen only once. While when such a electrode is created, it is created in such a way that it is lying in the interstitial tissue and continuously measuring the glucose. Some electrodes measuring every 1 minute, some electrode measuring every 5 minutes, every 15 minutes, like different technologies. And now we have the ways to measure these number and reflect on various meters. That's what has been the change which has happened in last 2 decades only. And that's how earlier we were measuring glucose by laboratory once in a month or so, just two readings. That was happening 4 decades ago. Then we entered into the era of glucose monitoring by glucometers, where it was possible to measure 4, 5, 6 readings a day. Still, these were snapshots. But now in the current era, we can measure glucose every minute in a continuous manner. That's how we can get a lot of information about what's going wrong in the biochemistry of a patient who is having diabetes.
So, what are the methods of CGM?
So, Rajiv, I have observed this last 20 years, initial CGM technologies, which where we were inserting a sensor, it was too complicated. We used to provide a shower bag to the patient with a big machine and they have to carry it, and that was measuring only for 3 days. So that means we insert a sensor in the subcutaneous tissue. This sensor is fixed on abdomen or arm, and now this is measuring glucose all the time. But earlier technologies were too cumbersome. And in last 20 years, there is a huge change. And now we have very small sensors like a 1 rupee coin. No wires, no cables. Just we put a sensor on abdomen or arm. And now this sensor is measuring glucose very frequently. And now we have technologies to transfer this data from sensor to devices, and that's how we can measure it. Now, if you look for the devices, there are many, but I will talk of three technologies which are available in India, which we are using here. One is a Guardian technology by Medtronic, where we insert a sensor. This sensor is measuring glucose, but in this technology, we have to do 2 times a day reading by glucometer and enter this into the system. Based on that glucometer reading, this technology will adjust and accordingly will provide us the glucose data. And this technology can give us glucose readings for a period of 7 days. That is Guardian technology. The second technology which is available in India, though not very popular, is Dexcom technology, where now the Dexcom version 6 is available. So we put a Dexcom sensor, no cables are needed, no calibration is needed. This is called factory calibration. And now for 10 days, we can see the data all the time on a Android or a iOS device, any Apple device. They have to download the app and we can see the data. That's the second one. And the third one, which is already available in India now, is the Freestyle, where we have two sub technologies. One we call Freestyle Pro, where we put a sensor on the arm, backside of the arm, and here patient has to come to us and then we can download the data. That's a professional variation version. And then recently, around 2 months ago, Abbott has launched the Freestyle Libre technology in India, where we put a sensor and we provide a glucometer-like device, which we call reader, to the patient. Now, whenever they put a sensor on their back of the arm, they can activate their sensor after 1 hour. And now, whenever they bring the reader close to it, it gives a glucose reading. Now, the beauty of all these technology, they are not giving just a glucose reading. They are simultaneously giving the glucose trend. That means at this time, is the glucose going up, it is stable, or it is going down. So that means it makes it a real-time technology. For example, somebody with a glucose of 82 milligram who's diabetic, let us consider maybe a type 1 diabetic. Now, when they see a value of 82, they are afraid that they may dip into hypoglycemia. Now, these technologies, since they are knowing the previous trends, every minute they are measuring. So now these technology not only give a number, they also give a direction of change, which comes in the form of an arrow. So if an arrow is upwards, that means the direction of change is upwards. You are not going down. And in addition, they give us a rate of change also. That means if the arrow is vertically up, the glucose is rising by 2 milligram per minute. If the arrow is obliquely up, that means glucose is rising 1 milligram per minute. If the arrow is horizontal, glucose is stable. And same thing for a downward. So we were talking example of 82. Now somebody with the 82 milligram, if the arrow is downward, that means you are heading towards hypoglycemia.
Hypoglycemia.
On the contrary, if the arrow is horizontal, that means don't worry, you are stable. So a lot of information these technologies are giving in addition to glucose numbers.
So the confidence of patients will surely build up when they are using a CGM. Now, tell me, what would be the indications for a professional sensor like a Freestyle Libre Pro versus a Freestyle Libre for patients? What would be the indications for each?
So it's a very good question because now two technology with a similar way are available. So let me tell you how I use them because there can't be very clearly defined indication, but what I do in practice. So those of my patients who can take self decision, to whom I want to train how they can adjust their diabetes by looking at the glucose readings, like most of my type 1 diabetic patients. I put them on Freestyle Libre because they are going to take a decision there. In fact, every type 1 diabetic can be put on a CGM
True, true,
because that's how they can bring their glucose most of the time in a normal range.
very true.
On the contrary, those patients to whom we know that we have to decide, they have a more or less fixed meal pattern, but they have little unpredictability in their glucose control, like many 60, 70-year age patients with multiple comorbidities. I put them on a CGM Pro, Freestyle Pro. They come to me after 7 days. I look at their reading, explain them, and I adjust their insulin doses. There, the CGM is put once, that's it. Maybe it may be repeated once again in a year. But when I put a patient on a Freestyle Libre, I expect that this patient will keep using this sensor more and more
More and
frequently
more.
and keep adjusting their glucose value.
Thank you so much. Now, coming back to this metric called time in range, can you explain to us what is time in range? How do we get to this time in range? And what are the values for time in range? What is the interpretation of time in range?
So when I entered into CGM technology, say in the year 2003, when it was launched in India. Since then, I am using that old version of CGM big machine to current era. But I tell you, we had a one big problem to talk about these graphs, how to explain the numbers, and like for a glucose you have fasting and PP number, for a HbA1c you have a number, but similar kind of matrix was not available for CGM technology. We had a visualization of the graphs and then so many numbers. Then 2 years ago they came to a conclusion that if we can measure those points during which duration patient's glucose was in a near normal range, that can be a good matrix to which they labeled as time in range. Ideally, every human being should time in range 100%, right? So say around, but for a diabetic, we defined a range of lower as a 60 and 180 as a above range. So during this range, if a diabetes is having their glucose most of the time of the day, ideally measured through CGM because we need many numbers. So if every minute we are measuring their glucose, doesn't matter for 15 minutes his glucose went up for 250. But if for 20 hours, 22 hours, if this patient remain in this range, then most of the time his tissues are exposed to near normal glucose. To this matrix we defined as time in range. And then we created different hour numbers that okay, this should be our goal, and if we can achieve this, we presume, at present we have limited data, but we presume that this patient will have less complications in future life.
So, do you think it is an emerging tool, and do you think it will replace HbA1c in future, or do we need more randomized trials on time in range? Because a lot of newer products are coming in with studies of time in range. So for basically, we both are people in the metabolic field, but for a physician, for a family physician who doesn't understand time in range, so how will he understand time? And do you think it will replace HbA1c in future?
I feel that HbA1c cannot be replaced, it will remain, and time in range will complement it. So a combination of HbA1c, because through HbA1c and glucose trends we can select those patients on whom we need to work more. Somebody who is having already a HbA1c of 6.5 and fasting postprandial glucose on SMPG most of the time in a normal range, then I presume that his time in range will be already optimal. But there are many patients who have wide fluctuations and their HbA1c is normal. That means that's an averaging effect because we understand that HbA1c can't tell us hypos or hypers. It is just giving us an average. So there are a subset of patients where we are going to utilize time in range, but for time in range, as we know, that 70 to 180 milligram, we want for more than 70% of the time. The remaining 30% of the time, 5% glucose can go for less than 70 and remaining 25%, 180 to 250. If it is going beyond 250, it should be less than 5%. That is what is our goal for both type 2 and type 1 diabetes. Now, to achieve this goal, obviously, patients will have ideally to undergo a CGM. So, that subset of population in whom we can do a CGMS, definitely there this tool will complement HbA1c and, in my opinion, will be superior than HbA1c.
So, for family physicians who do not use a CGM, there are some way that you can get time in range using a finger prick also. Do you think that is can be interpreted if you even if you have suppose 30 or 50 finger pricks in a day? Can it ever match up with the kind of information you get from CGM?
So, Dr. Rajiv, see, now the glucometers companies have also moved a lot. They've also created the graphs and these data which can be created for a time in range. But in clinical practice, patient can do more than 6, 7 pricks a day, maximum that much number we can get. While with CGM technology, we can get 1440 values in a day. So obviously, The real information for a time in range can come from CGM technology, or with glucometer technology also we can do a calculation of time in range. With a glucometer technology, if we have defined the goals for capillary glucose as the ADA is defined, that the fasting glucose has to be 80 to 130, and the postprandial glucose, if it is less than 120, if our patients are melting into this range, obviously there most of the numbers will come in time in range. So agreed that with finger sticks also time in range can be measured,
Can be picked.
but if you want a real in-depth information, you will have to do a CGM.
I always say that SMBG, CGM, and an HbA1c are all complementary. And since I come from Mumbai, whenever I speak about this, I say that the SMBG is like a trailer, the CGM is the real movie, and the HbA1c is like those stars which we get 3 stars, 2 stars, 5 stars. So all of them have to come together for the patient to get better. And importantly, the CGM and the real-time CGM, whether it's Guardian Connect or Freestyle Libre, will surely build the confidence of patients. As you said, the arrows will help them also detect what is the risk of hypoglycemia or hyperglycemia. So thank you so much, Dr. Sunil Jain, for enlightening all of us. And I believe that whoever would listen to us would, especially listen to you, would surely get enlightened and would really be kind of encouraged to use technology in diabetes, because it is evolving and now it is almost revolutionizing the management of diabetes. It's time that all people in the metabolic field should actually adopt technology, and that would help the end consumer, that's the patient, and we would help them in not only reaching their goals but also improving the quality of life. So thank you so much, Dr. Jain, for being here with us. And thank you for that
Raju, for
wonderful talk.
inviting me.
Thank you so much, Dr. Jain.
Thank you.
Dr. Ritu, are we good, or do you want me to ask anything more?
No, no, sir. This is not.
It's fine.
This is fine, sir.
Okay. Thank you, Dr. Jain.
Thank you, sir.
Hello, Raju.
Thank you,
Thank
sir. Good
you.
night, sir.
So
Okay,
see
bye
you
bye. See
sometime
you.
at Indore.
See you.
I'll
Yes, see
let
you
you know.
soon. Yes, surely. Bye
Okay.
bye. Bye bye. Thank you so
Bye.
much. Bye
Bye.
bye.